Hello, I'm Dr. Scott Tunison, a teaching and learning specialist in the Faculty Development Office in the College of Medicine, as well as a member of the MPAS faculty. In today's episode of the University of Saskatchewan's Saskatchewan Physician Assistant Podcast, we are exploring the question, what is a physician assistant? Joining me today is Ms. Rebecca Mueller, Director of the Master of Physician Assistant Studies program at the University of Manitoba. Dr. Ginger Ruddy, Director of the Office of Student Affairs in the College of Medicine and a family physician at West Wind's Primary Healthcare Centre. Dr. Tristan Domes, Academic Director of the Master of Physician Assistant Studies program, an Associate Professor at the University of Saskatchewan, and a urologist. And Mr. Ashley Milham, Canadian Certified Physician Assistant with 35 years of military experience and 15 years of clinical practice. Thanks to all of you for joining us today. The goal of this episode is to provide a better understanding of the physician assistant profession and to answer some common questions. Ashley, let's start things off with a question for you. What does a physician assistant do and where do they work?
Oh, great. Thank you for that question, Scott. Before I answer, let me give you some historical context where physician assistants came from so we can have a better understanding of the role. The physician assistant program in Canada began in the military. In the 1950s, the Canadian Armed Forces were training advanced medics, also known as 6B medical assistants, to provide frontline medical care where physicians weren't available. In 1984, they formalized this role, calling it a physician assistant, and began a structured training program to meet the growing demand both at home and abroad. With the military hospitals closing in the 1990s, the Canadian Armed Forces sought ways to maintain the PA training standards and began exploring civilian partnerships. This led to a pivotal moment in 2003 when the Canadian Medical Association formally recognized PAs as a healthcare or health science profession. A national accreditation framework was established, and in 2004, the Canadian Forces Medical Services School became the first program to receive a CMA accreditation for PA training. This collaboration laid the groundwork for PAs to enter the public healthcare system. In 2003, Manitoba hired its first civilian PA, and this was followed up by Ontario developing a pilot program in 2007, and then there was additional growth of PA employment in Alberta and New Brunswick shortly afterward. Civilian PA programs soon emerged at the University of Manitoba, and McMaster University and University of Toronto's consortium. From our military origins, the PA profession has now expanded into a coast-to-coast civilian healthcare profession. Today, PAs work in Alberta, Manitoba, Ontario, New Brunswick, Nova Scotia, and most recently, PAs have begun to practice in BC, Quebec, Prince Edward Island, and finally here in Saskatchewan, where the first publicly funded PAs will start work this month. So to answer the question of what PAs do, physician assistants are highly skilled, medically trained healthcare providers who practice medicine in collaboration with physicians. In a range of clinical settings, PAs work with one or more supervising doctors to extend physician services and improve patient access to care. PAs take patient histories, perform physical exams, order and interpret diagnostic tests, develop and implement treatment plans, and assist in surgeries. In many settings, they're also able to prescribe medication. Their scope of practice depends on their supervising physician and the clinical context that they're employed in, allowing them to adapt across specialties and clinical settings. You'll find PAs right now across Canada in family medicine clinics, emergency departments, cancer centers, specialty medical clinics, surgical units, long-term care homes, Indigenous communities, and a variety of rural and remote regions, such as fly-in northern communities like in Manitoba, where their presence directly improves healthcare access and continuity of care.
Wow, PAs are really in a lot of different places. One question I have for you is, what drew you to the PA profession, and what do you enjoy most about being a PA?
Well, the part I enjoy the most about being PA is actually the contact with the patient, enabling the patients to get that care effectively and efficiently, by enabling the doctors reach and seeing more patients, enabling more people to come get their medical care sooner. That's really the crux of being a PA is making our healthcare system a little more efficient and making patients feel valued within our system.
That's great. So what does a typical work day look like for you when you're working as a PA?
Oh, most days start fairly early. 7:30, 8 o'clock in the morning, we'll arrive in the office and prepare for our day, depending on what role we're filling, whether it be a family practice or emergency medicine. Prepare for our shift, like most healthcare professionals. Anticipate our day, get our get our offices ready, and then through the day we'll see our patients. Usually, routinely, anywhere from 8 to 15 patients. We'll see them, take their histories, listen to their concerns, and advise them on the best methods of taking care of their conditions or presenting us with. Throughout that day, generally depending on the clinical practice and the severity or the complexity of the patient, I might see my supervising physician either directly after I see the patient, or maybe even consult them concurrently with the patient, and so the patient has that understanding of their condition and what we're going to do for them to take care of them.
That's really helpful. Boy, you're a busy person during a work day, aren't you? One last question I have for you right now is another frequent question we hear is how are physician assistants compensated?
So across Canada, it varies, but the majority of physician assistants are salaried employees. The salaries generally, those are primarily ones who work in a hospital or a clinic. There are a few who work directly for supervising physicians and paid hourly wage, but generally the physician assistants are paid by the organizations they work for in collaboration with their supervising physicians.
Thank you very much. That's really helpful information. Now I'd like to switch to our colleague, Dr. Ginger Ruddy. And Dr. Ruddy, you have worked with PAs in the past. How does the physician and physician assistant dyad work on a day-to-day basis? What does it look like?
I think, as Ashley has indicated, of course, PAs are in so many different systems, but I'll describe a couple of different contexts in which I've worked with PAs. First, in a family medicine clinic where the PA is seeing their own slate of patients, but much like a medical trainee would check in with me after seeing the patient and say, hey, this is the plan that I've come up with. And so what that means is that a significantly larger number of patients get care that day. And the patients still have a physician overseeing the care, but they get a provider. And we know right now, so many Saskatchewan residents are desperate for a primary care provider. And the PA can fulfill that role and be their first point of contact with the medical system and create a place where they understand that they're cared for by this team of people who work together. And so that's been extremely valuable. And then other contexts, when I worked in the emergency room, we had PAs who were involved. And of course, this was in an American context. And in that context, lots of individuals, not unlike here, end up using the emergency room for less than emergent conditions because they need to get care and they're not sure where else to do so. And so the numbers exceeded what would have been feasible with the number of doctors we had, but because we had a skilled set of PAs, together we were able to increase the volume of patients we could care for in that context. And just like any healthcare relationship, as you get to know one another, you understand, oh, my PA has, for example, significant experience in oncology. So when I see a patient come into the ER with a concern relating to their oncological diagnosis, I'm going to start with him because I know that he's going to have more experience than I do. And in other cases, he might say, I haven't worked with a ton of newborns. Can we work on this together? So it's very collaborative. It's very relationship based. And for that reason, I think it feels like a great solution for Saskatchewan.
Great. Thank you very much. Did you encounter any challenges working with PAs and how did you overcome them?
I think not unlike we're experiencing in Saskatchewan, there's just a limited understanding of what PAs do. And so it would involve explanation and education, sometimes to a patient or their family member who would say, why aren't I seeing a doctor? Well, you're seeing the person who can see you the soonest and who can collaborate with me to get you the care you need the fastest. And so that tended to be really effective. And again, once the patients and their families get to know this PA as a member of the team, they recognize that they're actually getting better care for having more people who are involved with their experience and more people shepherding them through the system, which can be complex and difficult for everyone, especially if you don't have enough hands guiding the process.
Makes perfect sense to me. So it occurs to me then, how has working with a PA changed your role as a physician?
I think when I was in teams that had PAs, what ended up happening was that I got to work to top of scope more frequently. So a lot of what a physician does, especially in our fee-for-service context in Saskatchewan, is not medicine. It's administration or social work or trying to be a dietitian or trying to be a physio. It turns out I'm terrible at all of those things. And when we have a larger number of individuals on the team with related skill sets, then the patient gets the care they need from the person they need it. And what it means, for example, is if someone comes in with a urinary tract infection that seems reasonably straightforward, they're a healthy person otherwise, that, for example, doesn't need my care. That can be seen by my PA. And then if my patient who happens to be immunocompromised comes in and their urinary tract infection has extended to their kidneys and might require hospitalization, I can see that patient. And that's a more effective way to use the healthcare resources in that context, because more people are getting care, fewer people are sitting in the emergency room waiting to be seen and potentially getting exposed to other illnesses while they're there. So it's a system that allows people to get what they need when they need it better.
That's a great way to describe how the PAs impact healthcare in general. So do you think as we get PAs trained here in Saskatchewan and we get them added into the overall ecosystem of healthcare in Saskatchewan, do you think that overall healthcare will improve for Saskatchewan residents?
Absolutely. I wouldn't be here if I didn't. From the perspective of patients needing a family physician, PAs mean that a family physician can have a larger panel of people for whom they're responsible for the care. So even though we're not increasing the number of doctors very fast, we can get more patients taken care of with the number of doctors we have, with a skilled population of PAs. Similarly, in the specialty community, when your consultant is spending a bunch of his time doing the straightforward history and physicals or straightforward post-surgical follow-ups in hospital, those are often best shared with a physician assistant who then raises areas of concern to the physician. And what it means is we can shorten those wait times to see specialists, which all of us want. Similarly, having a skilled assistant in surgery could mean that a surgery can go forward, which couldn't when we didn't have a skilled PA to take that role. So there are lots and lots of places where we can use this extension to physicians as a way to improve care for everyone in Saskatchewan.
Wonderful. Thank you very much. Now I'd like to switch to Rebecca. Rebecca, as a physician assistant educator in the University of Manitoba, what benefits do PAs provide to the province of Manitoba? And do you think we will see similar benefits in Saskatchewan as we introduce PAs here?
Thank you for the question, Scott, and thank you to all of our panel members here today. So as Ashley had mentioned earlier, PAs began their employment in Manitoba back in 2003. Our program, however, started and opened in 2008, and we have graduated many physicians now, recently expanding our program from 15 learners to 30. And the reason this expansion happened and the reason we are seeing almost an explosion of programs across the country is because of the very well-documented benefits that PAs have had. So yes, I think Saskatchewan will see great benefits, just as Manitoba, Ontario, the entire US, and many other countries have seen. PAs are there to extend the services of the physicians that we work with, which has been exemplified by the other panelists already. If a physician is scheduled to see a roster of 20 patients in that day, or in some cases 30 or more in a day, a PA typically can expand the capacity of patients seen in a day by 40%. Sometimes more, sometimes less, but we have evidence of a pretty standard 40% increase by adding one PA to the team. So now we're talking about in primary care, where we have so many patients without being attached to a primary care team. We're immediately increasing that by 40%. The dramatic impact that has on a patient's life is huge. I mean, they suddenly have quick access to, relatively uncomplicated things like coughs and colds, other URTIs, strep throat, UTIs, things that still need to be seen urgently but aren't overly complex. But also PAs can deal with more complex cases, such as chronic disease management and diabetes care. Someone whose insulin levels, they're having trouble managing how to give their insulin. Yes, we have nurse educators for that, but PAs can also step in these cases. Congestive heart failure, cancer cases, sending in referrals, following up on that blood work. And that's just in a primary care setting. Once we get to talking about a specialty care setting, it's the same similar impact. We have a dramatic increase in the number of patients seen in a day, a dramatic decrease in wait times, both for specialists as well as ER settings. So for example, when I was working in oncology and palliative care, I would absolutely go through and see the new consults. I do all of the admissions, all of the discharges, the regular follow-ups. This is going to make a dramatic impact in Saskatchewan. Team-based care is the future, and we are absolutely part of it.
That's wonderful. So do you also see a role for PAs in rural and remote areas? And what does that look like?
This is actually what I think a relatively untapped area across Canada that PAs can almost bridge the care in a way that we haven't done in the past. So in Manitoba specifically, we have made huge strides, and I really can't take credit for this. These are other PAs, Tara Clark, Lisa Moore, who have really opened the door for PAs, a number of PAs practicing in remote fly-in areas. It is the second largest employer, Angamas and Health Service, second largest employer of PAs in the province. It is solely due to these PAs working in remote fly-in communities that nursing stations were able to stay open during COVID. Without these PAs, multiple nursing stations across northern Manitoba would have closed and essentially prevented zero patients, no care would have happened throughout COVID. So these PAs have done a huge service to the community, and it feels good to practice up there. It is the most requested place for our students to go and rotate. They're continuing to hire more and more PAs. It is where people want to work because they can practice to their full scope. Right. So, and I'll clarify, in these remote areas, PAs who are experienced can practice under direct or either indirect supervision with the physician. So that supervising physician in a remote flying community might be at a different fly-in site, but available via phone. So should something happen that PA doesn't know what to do with. But that experienced PA is able to practice with indirect supervision, which is really spreading the care across a large demographic and a large geographic area that otherwise would not have it. So this is pretty impressive work that these PAs have done in our northern remote areas that I hope we can continue to spread across the country.
That's really, really exciting. I didn't know about that. So tell me a little bit more about how a PA works sort of semi-independently and relates to the supervising physician. Like, how does it happen right away as soon as they finish PA school? How does that happen?
Right. So as we all know, it's the obvious thing here. In 2 years of a PA program, how can a PA graduate and know how to practice in this incredible scope that we've just described, right? And the reality is that a newly graduated PA is not able to practice in that manner. And the expectation is that they do require hands-on learning and training after graduation here. So they graduate from a PA program as a generalist provider who's able to walk in, take a history, do a physical, and have a basic differential diagnosis and plan to move forward, okay? But they do need to follow up fairly closely with that supervising physician. In fact, I would say the first year after graduation, they're still really acting like a student. They might be prescribing at that time, but that relationship with that supervising physician, or maybe multiple supervising physicians, is knit tight, very close. The level of trust that has to exist between the PA and the physician has to be unbreakable. That physician needs to know without question how exactly that PA is practicing, and that PA needs to know exactly without question how the physician would practice. So there's no question going in between, right? We do have studies from the US. I don't have the data replicated in Canada just yet. Maybe one of us will do that someday, but some data from the States does show that it takes about 3 years after graduation for a PA to be, truly an expert in that specialty that they've chosen to practice in. So you'll notice that there are various specialties that have developed a unique training program. It's not a formal training program that gets a certificate at the end of the day, but is an onboarding process. So in, for example, Ongamas and Health Services, they generally hire experienced PAs. There are some exceptions to that, but it is generally speaking a PA who's had some practice experience. And then they have, a 3 to 6 month, very closely monitored onboarding process that involves the supervising physicians as well as existing PAs in the practice and existing nursing staff in the practice to make sure that the team sees the dynamic, right? And we have another example, which is actually very urban in our ICU in Winnipeg, which has a 6-month onboarding process for PAs that they hire. And this onboarding for these PAs includes both didactic training as well as procedural training, so that they're able to really be experts in that specialty. It does take time. It takes time. But once we're there, that investment really pays off.
Thank you very much. That's really, really helpful. Now I'm going to switch over to Dr. Domes. As we've heard from our other guests, PAs might be new to Saskatchewan, but they're certainly not new everywhere in Canada and internationally. What do you think the impacts of introducing PAs and the MPAS program will have in Saskatchewan?
Yeah, thanks, Scott, for that great question. And I think Becky's answer really helps to sort of show what PAs can do in a jurisdiction in Canada that's very similar to Saskatchewan. So Manitoba is 20 years ahead of us, but you see what it's done, right? It's allowed for care to happen in communities where care is not happening now, at a level where patients are getting that care in a timely fashion. And what that does is it just helps the whole system. Right now in healthcare, a lot of us are experiencing some moral injury because we feel like we can't help the system. Where I see PAs as an opportunity to actually break that and to get people getting joyful again about their work, with the impact, of course, being that patient care.
Right.
So that to me is really, really important. But there's other spin-off benefits too. Like there's been studies shown where bringing a PA into a team actually also helps, obviously, the physician burnout, but also helps trainees. It allows, there was a good study done actually in urology in Toronto that showed bringing PAs into their team there helped the residents and the fellows with their educational goals and with their training. So there's so many spin-off benefits. And with some of the things that are happening in this province, innovative strategies like virtual health, bringing PAs into that would just also, I think, open up a huge blue ocean for healthcare in the province. So I feel like although we're a bit late to the game, we have a lot of internal capacities and people in this province that can truly bring us to the next level to improve our system that we know now is not working. We have to do something different. And to me, PAs is one of those solutions to help.
That's really exciting, and it's really interesting to hear all of the different ways that PAs can contribute into the system. One of the things that I'm excited about with the PA program is to get to teach in the program, and I'm curious what you have found in terms of the student response to coming into the MPAS program. What does that look like?
Yeah, it's been amazing. Of course, when you start a program, you don't know what your applicant pool is going to be like or what the general sentiment's going to be like. But we were blown away with a fairly quick and short admissions window. We had over 340 applications to our program. And a lot of those people were from Saskatchewan, which is just tremendous. So, thanks, Becky, and your program for leading the way and building, I think, a strong foundation. But people are very interested in this career. We have people who, of course, come from the typical sort of pre-medicine or health science background, but we've also had people from different backgrounds and diverse backgrounds, more mature learners coming in and wanting to contribute to our healthcare system. So to me, it's really, really exciting, and I think it's just going to grow. So, because this profession adds something different. It's different than what we have now. Some people want to be in that type of role, want to contribute in that way, in a direct way, and not having to do as myself, right, 10 plus years to get there. So I think there's a lot of opportunities in this program, and I really want to commend the government for thinking ahead and thinking, okay, we need to have a training program if we're going to supply our province with PAs.
And of course, as we always say, if you want a different outcome, you have to do something different. And as you say, PAs are a new idea and a new role in the healthcare sector that may be very helpful. So the last question I have for you before we move on to some open questions is, who do you think will benefit the most from the new MPAS program?
I think our number one goal in anything we do in healthcare needs to be focused on the patient. So I think our patients in the province are going to benefit the most. But that doesn't mean the other groups won't too. I do truly think that physicians as well are really going to benefit from this. Other members of our healthcare team are going to benefit from it, and the whole system's going to benefit from it. But in the end, we are all working together for that patient, right? So if our vision isn't aligned with that patient goal, then really this program doesn't have a standing. But that is where I think the biggest benefit's going to be. And that will just help everyone, right? Because if the patient care is better, as a provider, I'm feeling better. Our family physicians are feeling better, our specialists are feeling better, our nurses, right? Our emerge rooms, our ICUs. So, it's a way for us, again, it's not the only solution.
No.
It's one of many solutions, but to me, it's going in the right direction, right? Because we can't keep doing what we're doing and expecting we're going to get a different result.
That's very helpful. Thank you very much for that. The next part of this podcast is we're going to open it up to a little more open conversation. And the first conversation I'd like to launch is we hear a lot of questions about the difference between a PA and a nurse practitioner. And I'd like to open the floor a little bit to a conversation about how they're the same and how they're different. And I thought perhaps I'd start, Ashley, with you. From your perspective, how are PAs and nurse practitioners similar and or different?
Yeah, nurse practitioners and physician assistants are both advanced care providers. There is some similarities, but there is some differences in training and how we practice. Nurse practitioners come from a nursing background, and they complete a graduate level nurse practitioner program and practice independently under nursing regulations. Their model emphasizes the holistic patient-centered approach, and they're often found working in a primary care setting. Whereas PAs, we're trained under a medical model, very similar to physicians. Here in our province, the PAs are regulated and licensed under the College of Physician Surgeons in Saskatchewan, as are the physicians, and we practice in collaboration with our supervising doctors with a delegated authority. While we diagnose and treat and prescribe our medications, our scope is defined by our supervising physician and the workplace. We're very flexible generalists who can work at any medical or surgical specialty as long as the supervising physician has expertise in that field. But that being said, both professions improve access to care, but really our professional roots and regulatory frameworks differ.
Thank you very much. Now, Rebecca, as a leader in Manitoba, what do you notice in terms of the differences between the two and how those two roles play out in the healthcare sector?
So I think this is probably a long-standing issue of confusion, and hopefully it doesn't continue, but it might, because there is overlap between the scope. But I really like how Ashley distinctly noted that nurse practitioners are practicing independently, whereas PAs are practicing in collaboration. So this means that we typically do not have our own roster. The physician has their roster, and we will see a load of patients in the day, but at the end of the day, it is still the physician's patient, whereas the nurse practitioners will hold their own roster. So that is one difference, that the amount or level of collaboration can potentially differ. That being said, there is space in primary care teams for both PAs and NPs. In fact, they are needed. Both of these professions are needed. There are so many patients, such a great workload that we really all need space here, and our patients need us to be there. The other thing in that primary care team setting that I think is important to note is that we might notice these differences on our end, and we could go into detail about what those are. But from a patient perspective, other than us explaining our title, patients should not know the difference, because the care they receive from a physician, an NP, or a PA should all be meeting the standard of care. Everyone should be receiving the same high quality care from all three of those professions. So I think it is very important to note that at the end of the day, the patient walking away should be receiving the same level of care, because we are all beholden to that with our regulatory bodies. The other difference that you will see is within the specialty setting. So, for example, in surgery, PAs are much more likely to be found in a surgical setting than nurse practitioners, and that simply has to fall back on the training and the regulation. So you will see different specialty opportunities if you are working as a PA versus working as an NP. But really, we're all diagnosing, treating, seeing patients with a standard of care that we share.
Thank you very much.
Yeah, I'd like to chime in
Yes.
too, and I completely agree with what Becky says, and you know, our system needs more people. The healthcare needs are immense. We need to look at it from that perspective, and you know, our program, the MPAS program, is very much about collaborating with our nurses and nurse practitioners. There's huge value in that partnership. And we see the value and the scope of practice and what they provide the system as invaluable. So we're not saying it should be physician assistant or nurse practitioner. It's like the system needs both. You know, in a complex system as we have in healthcare, we shouldn't be sort of parsing out it's so granular. We need to work together. But that doesn't mean that the scopes don't have some overlap. But there's going to be overlap in all scopes, especially now as we're looking at providers, whether that be pharmacists, whether that be nurse practitioners, physician assistants, you know, and others who are extending their scope of practice because there's a need, right? The problem is that there's an imbalance between supply and demand. So we have to increase our supply because I'll tell you right now, the demand is not going down. If anything, the demand's going up.
Right.
So we all need to step up. But it's not meant to be a PA versus NP. I think it's important for people, especially us, to understand the difference. But I very much welcome expansion in nurse practitioner. I very much hope that we continue this really solid collaborative relationship we're building, and we learn together. That's the key.
The one thing that comes to mind as we've talked about the health human resource crisis in Saskatchewan, we've talked about this idea that our best odds of getting a workforce here are by training our own. And one of the things that I love about the PA pipeline is the fact that it's shorter. And as you indicated, you had applicants from all different sorts of backgrounds. And what it means is that if someone lives in a rural or remote community and thinks, I'd like to be making a contribution, and they have a degree, then in 2 years, they can come back and be contributing to that community, which isn't feasible if because nurse practitioners need both the RN and then the NP, or medicine, you need the MD and then the residency. So it's this way that will allow folks who want to make a contribution and might be mid-career or might have other things that they've been working on to date to join the healthcare profession and come back and work in a community where they have strong ties and strong relationships, which of course is best for patients, right? You want those to be trusted people who are known to the community, and so it sets us up for a kind of success that I'm hopeful will change who has access to becoming a healthcare provider and who chooses to do so.
And in our program, we're being very deliberate about that connection. So people that are in different communities and want to go back, and ideally, you know, we will encourage them to. We're trying to link those educational opportunities in those communities for their training to the individual. So they have a chance to actually go and work with those individuals and healthcare teams in their communities they want to work in, so we can build that up. So important, because right now our system does have that siloed approach where we have our educational systems, and then we have our healthcare needs, and then we have our hospitals and clinics and everything. And this program, I think, is an opportunity for us to bring them all together and really to build that synergy, like you say. And because we're 2 years, we have more opportunities to do so.
That's wonderful. Thank you very much. And thanks to all of you for joining us on our first Saskatchewan PA podcast. It's very, very exciting to hear all of the wonderful opportunities that future PAs have in our province. And it's also really exciting to hear physicians who are practicing in our province be very excited about the possibilities of having new colleagues across the province and to improve the patient outcomes and patient care across the province. And it's really, really, really exciting. Thank you very much for joining us and coming in with us today. In the future episodes, we're going to be talking about things like licensing. What does it look like to become a PA in Saskatchewan? How does a person get a job as a PA in the province, and a whole bunch of other topics that we will explore over the next several months. Again, thank you very much to our guests for joining us, and thank you for tuning in as well.